Hello, everyone, and welcome to the Ramalinga Center's colloquium series on equity and social determinants of health. Very excited today to host Dr. Sreeparna Chattopadhyay, who, besides being a really brilliant scholar and has done exceptional work on the issue of obstetric violence and other forms of violence against women, is also an old friend of mine, and I'm very happy that she's agreed to be our speaker for today. For over 18 years, Dr. Sreeparna's work and her research and her teaching and her advocacy has focused on gendered violence in India, intersectional health inequities affecting religious minorities and Adivasis, and reproductive politics through biocultural and political ecology frameworks. Her book, The Gravity of Hope, which I recommend highly to everybody, explores the links between domestic and structural violence. Her work has been supported by many international grants, including from the NSF and the Guggenheim, and she has published widely in many peer-reviewed journals. She's a committed public scholar, and she contributes to digital media and the press, and her research has been featured in national and international outlets, including the BBC. Her current work centers on reproductive justice, respectful maternity care, voluntary childlessness in urban India, feminist bioethics, and the politics of knowledge production. Sreeparna has a PhD in cultural and medical anthropology from Brown University and a BA in economics from St. Xavier's College in Mumbai. She's a professor of practice at Manipal University in Bangalore and a visiting faculty in sociology at Flame University in Pune. She is a co-editor of Feminist Anthropology, a journal of the American Anthropological Association. The work that she'll be presenting today is, I'm proud to say that I journeyed along with her for a little bit of it, and I'm excited to hear what she has today and hope that leads to, a sort of engaging discussion afterwards. I request people to put their questions in the Q&A box. You can put them in as and when they occur to you over the course of the talk, and we'll pick them up for discussion at the end of her talk. Thank you so much for being here today. Sreeparna, floor is yours.
Thank you, Abha, and to the Center for inviting me to share my thoughts. Reproductive health, sexual and reproductive health, rights and justice, and especially maternal health are issues that are very dear to me. And in this lecture, I have a single goal. I don't know how, whether or not I'll be able to accomplish the goal, but I will try my best. And my goal is to use the concepts and theories drawn from the German sociologist Ulrich Beck, the British sociologist Anthony Giddens, and the work of several medical anthropologists to understand what appear to be contradictory, counterintuitive, or just puzzling with regard to some select interventions on maternal health. So let me start with sharing my presentation. Epidemiological notions of risk. I first encountered epidemiological notions of risk during my postgraduate training at Brown University in demography. After my master's, I started working as a qualitative researcher on an HIV/AIDS project in the summer of 2003. I was barely 23 years old and had not yet been introduced to the sociology of science or anthropological critiques of risk or frameworks like structural violence or political ecology.
Sreeparna, just one second.
Yeah.
I think the screen we're seeing is the next slide as well. It's not a full screen slide.
Oh, just give me 1 second. Are you not able to see it?
No, yeah, not the full screen. We're seeing.
Now?
Yes, but it's still not full screen, but we are seeing only a
Oh, not sure why that is happening. Shall I continue?
Sure. Okay, this is fine, I suppose. Yeah, but we're not able to see the full screen right now. The top of the screen is being cut off. There we go. Now it's good.
Okay.
Thank you. Yeah.
So I believe for many of us who were introduced to health sciences or medical anthropology or sociology in the early 2000s, the fear of HIV/AIDS loomed large. Funding followed this fear, and many projects aimed at tackling risky behaviors, at-risk individuals, prevent risky situations, etc., became viral. My first academic presentation at the Population Association of America was based on this research to prevent HIV/AIDS among working class men who practiced unsafe sex and put their monogamous wives at risk of contracting STIs and HIV/AIDS. It was provocatively titled Frisky Men and Risky Sex. The 23-year-old me felt very smart, and I believed I had captured the zeitgeist. 2 decades later, I cringe when I read this title. I had internalized ideas of risk dominant in public health and biomedical sciences without even realizing it. The project was headed by a medical anthropologist. The funding was through one of the most scientific organizations in the US, the National Institutes of Health. And what was being privileged were well-known epidemiological categories of risk. So as you can see from this slide here, the way in which risk is measured in epidemiology is at the population level, although there are individual measures of risks as well. And it is a calculation of the probability of an event. It's bounded by time. So if we calculate how close it is to a particular period of time, and the individual who is initially risk-free can develop the disease or the condition within a particular time frame. And this is the formula which you see to the right, or my right at least, is the formula for risk. So what is risk? So if we go back to one of the sociologists that I looked at in terms of understanding or critically understanding risk, so epidemiologists calculate measures of relative risk to compute the likelihood of illnesses developing in populations exposed to a risk factor with the likelihood of for populations that have not been thus exposed. State-sponsored health education campaigns in the mass media are conducted to warn the public about health risks based on the assumption that knowledge and awareness of the danger of certain activities will result in avoidance of these activities. End of quote. This is from Deborah Lepton in her 1999 essay on risk. Sociologists of risk like Lupton and trenchant medical anthropological critics argue that a discourse of risk with labeling individuals stigmatizes them and knowledge does not always translate into change into attitudes, behavior, and practices. The famous KAPB models, which I'm sure many of you are familiar with. These have never fallen out of favor within mainstream public health. Even today, these notions of risk form the backbone of public health intervention. If we offer enough knowledge, this can change attitudes, which in turn can change behavior and modify practices in the long run. Unfortunately, from preventing smoking to parenting strategies, this model has proved itself to be inadequate for many reasons. People who know and understand risks still continue to engage in these behaviors. The expectation that education is the primary route to social transformation, I would argue, is both naive and reductionist. But this does not imply they are entirely useless. Some studies indicate that educating children, for example, when they're sufficiently young about climate change, can inoculate them against disinformation and misinformation campaigns about climate change later in life. My preoccupation with risk did not end there, thankfully. My subsequent anthropological training compelled me to interrogate these categories of risk. How did we determine what was risky? Who was at risk and why? Why did we use this discourse of risk? What is its genesis? Was it useful? Did it alleviate suffering? So this section is entitled When Nearly Everyone is at Risk. What if the majority of the population was at risk of developing a certain condition? This was brought home to me most resoundingly when I began my first research project in maternal health, a thematic focus that I continue to engage with in Assam. On a cold winter day in December 2015 in rural Assam, our research associate, Reniki, and I were conducting observations and interviews in a newly constructed tertiary hospital in one of the better performing districts in a state notorious for its maternal mortality ratio. As we stood outside the pre-labor room, it hadn't quite taken the shape of a full-fledged ward. A young married woman approached us. With our institutional bag revealing my academic affiliation and a pen and a notebook, I could not have looked less like a researcher. This Bengali woman initially asked me for assistance in Hindi, and as I was trained to say, my first response was to proclaim any lack of expertise in biomedicine. I am not that kind of doctor, I told her. She spoke beseechingly in Bengali. Didi oder ektu bojhan. Please make them understand. My task was to convince her pregnant sister in law's husband, her brother in law, that her sister in law, let's call her Sheila, must be transferred to the medical college in Guwahati. The doctor had thrown his hands up in the air and had mandated they go there, 30 kilometers away, that seemed a continent away for this rural family. Sheila was not severely anemic, but her hemoglobin level was at 8, refusing to budge despite every possible biomedical intervention short of a blood transfusion that the hospital had given her. They had used their Brahmashtra, akin to Thor's hammer, an iron sucrose infusion, but even that failed. This new hospital did not have a blood bank or a NICU or a functioning OT for an emergency C-section yet. From the doctor's perspective, Sheila was at a heightened risk of developing complications associated with anemia. This, as we know from the canons of epidemiology, can range from postpartum hemorrhage, preeclampsia, eclampsia, low birth weight baby, babies born with neonatal complications, or even death for the mother or the baby. Naturally, he did not want to take these risks on. The hospital was still not at the stage of defining protocols for transfers. Such written protocols when a pregnant woman should be transferred were unwritten and often informal, something that I was to discover many years later during my fieldwork in a very different context in rural North Karnataka. The family was reluctant to take Sheila to the hospital more than 30 kilometers away, and they had their reasons. This would involve additional costs, inconvenience, and why could she not just birth here, closer to home, just like her sister in law did? Additionally, the GMC, which is the Guwahati Medical College, had the reputation for being dirty, rude, and inconsiderate to patients, and stories of where many women had died. The doctor and the patient were both in the belly of the beast. I was initially a spectator in this battle between a poorly functioning public health system, patriarchy, and something else. Amorphous like a wisp of smoke that I could not quite hold on to at the time. It was not the first time I was asked to intervene as an observer, and neither would it be the last time. As they huddled together was the first frustrated physician trying to convince them repeatedly in Assamese, Iat noi, GMC oi loya jao. Not here, not here. Take her to GMC. The birth of the child cannot happen here. You have to take her there. I gave him a sympathetic look. He was aware of our project, and we had been visiting the hospital daily for nearly a week. I came over to speak to him with Sheila's sister-in-law following me, increasingly anxious, aware that we were losing precious time. I asked the doctor in Assamese, Moi chesta koru? You want me to try? He did not think it would make a difference, shrugged his shoulders, and told me, Dekhun apuni ki koribe pare. See what you can do. The family understood and spoke Assamese fluently, like all Bengalis from Assam. So language was clearly not the barrier here with regard to communicating with the doctor. But they did not understand or perceive the risks the same way the doctor did. In this instance, epidemiological language was failing the translation test, and quite spectacularly at that. I called the husband aside and spoke to him in Bengali. I told him, You have to take her to GMC so she and the child will have a fighting chance. I urged him, Listen, there is no blood bank here. If she needs a transfusion, which she will, the hospital cannot arrange for it. In the end, I also told him that my mother had almost died giving birth to my sister because of complications associated with childbirth. So this memory actually of, my mom almost dying during childbirth, in fact, remains one of the most defining moments of my childhood, to speak in a minute, in a manner of speaking. For a few seconds, he was stunned, perhaps by my bluntness, but if this is what it took to save this woman's life, then at the moment I was comfortable with this level of bluntness. He conferred with his parents and they decided to get into a magic, this red van that you see here. A small tempo traveler that was the primary means of transportation connecting the villages to the city. The magic van was truly magical. It managed to fit in many more people than you would expect it to be. But they had to take Sheila lying down, so they had to compensate the magic driver so he would not pick up more fares who would occupy the back seats. Renike and I were glad that we had succeeded, but of course, my mother's story was far more complicated than just anemia. However, I did not know the words for a ruptured placenta in either Assamese or Bengali, or sepsis, or a botched up C section. Returning to the question of risk. Why did the family not perceive risk the same way the doctor did? Ulrich Beck, the German sociologist, in his book Risk Society, argues science determines risks, Niputs determines risks in quotes, and the population perceives risks, also in quotes. Deviations from this pattern indicate the extent of irrationality, in quotes again, and hostility to technology. So all these phrases and words and quotes, at least to me, conveys the idea that Ulrich Beck was not entirely convinced that these are real things. Whether does science really determine risk? Does the population really perceive risk? Are deviations from this pattern truly irrational? And does it really indicate a hostility to technology? If you read his book Risk Society, there's a far greater clarification of all of these terms that he uses, as well as how to understand these complex issues. As I were to discover during this long-term engagement with maternal health, it is not unusual for doctors to complain to researchers that it is the uneducated and illiterate, the poor and the working class who resist technological intrusions into obstetric care, or alternatively, and sometimes paradoxically, demand too many interventions, even when not needed. Note the following conversation between an intern and me on the theme of respectful maternal care that was conducted by an interdisciplinary team when I was a member of this particular center as well, and some of the people who are probably in this hall today, we work together. So in this, as you can see from this quote here, so it's an excerpt from an interview with an intern who was on her OBGYN rotation in a tertiary facility. We were discussing the role of that communication might play in respectful care. So I asked her, so the doctors have advised a C-section, but the family does not want to do that. Are you trying to say that when she was referring to gaps in communication? And then she says yes. So then I ask her, why would a C-section be refused, you think? They may think it is an operation. They may feel delivery will take place normally. So they will say, try for normal. It may progress, They will leave, they will have that thinking. They will not understand. Sometimes it will occur also, but the baby will be in distress. Baby will have to be admitted in NICU. I probed further. Was this a communication difficulty or something else? Education. They will not be knowing anything about what is the issues. Patients will come to the OPD and they will be asking the same thing. And she was telling me this with some sense of frustration. Yesterday, I saw a case in OPD. She was a case of an ovarian cyst posted for laparotomy, so some kind of laparoscopic diagnostic facility procedure. They gave blood yesterday. Also, they gave blood previously, and also for the same test. And they will also get it done from outside as well. They did not have that much knowledge that they have already given blood for tests here. The reports will be ready in 4 to 6 days. They do not understand when the reports are coming here and that time and why to go and give extra blood for tests. They did not know that much also. Less education and less knowledge. So she identifies these as the problems. There are some interesting insights that emerge from this snippet. What R1 is telling us is that the family mistakes C-section for a serious operation. C-section is in fact classified medically as a major operation whose benefits need to outweigh the risks, even if doctors do it routinely, which reduces their perception of risks involved in this procedure. R1 is also agreeing that progression of labor can be uncertain. It may progress again, stall, needing emergency intervention. Fetal distress may occur. Although minimal fetal distress may not be the only reason to do a C-section. The baby may be delivered normally, but may need admission to NICU. R1 is a young doctor, really a doctor in the making, and here she is outlining a nearly comprehensive range of possible uncertainties in this process of childbirth. Yet, when patient families dither around decision making because they are unsure of this uncertainty, which she herself as a doctor admits to, they are classified as medically illiterate. The slippage in illustrations from a woman who needs an emergency C section and is unable to understand what this means for her to a woman who repeatedly gives blood for a planned laparotomy illustrates this thought process. This section is called On Uncertain Grounds. Popper argues, this is Karl Popper, the philosopher of science, that science is built on shifting sands of uncertainty. In fact, the principle of scientific advance is that science has to be open to revision. Take the everyday example of eating eggs. Good to bad, it is back in the good books again if eaten in moderation. What might be some of the ways to sociologically understand risks and use interpretive methodologies that go beyond obvious understandings of how risk perceptions develop, how it is processed, and distinguish between types of risks? We live in a risk society. A risk society is one where we live on a high technological frontier, which no one completely understands and which is capable of generating a diversity of possible futures. Many health providers' responses, which appear to deviate from medical protocol, whether these are for C-sections, inductions, or something else, can be understood using this explanatory framework. In rural Assam and rural Karnataka, we are witness to such deviations, which in fact have become normative. Let us look at the example of routine episiotomies. Episiotomy is a procedure to widen the birth canal in order to enable the baby to be born easily. It's a surgical procedure and needs stitches later on. The WHO recommends that no more than 10% of births should warrant an episiotomy. But we have evidence that most births, particularly first birth in India, are subject to universal episiotomies. One might argue that this is the nature of obstetric practice, where doctors in training learn to do this from seniors. But that still does not explain why, knowing fully well that they are deviating from protocol, doctors continue to train juniors in this way. Note the following conversation between a doctor in a district hospital and me when I asked him about episiotomies. This was the same doctor who was grateful for my intervention regarding the referral to the GMC that I mentioned at the beginning of this talk. I had the opportunity to observe him for 2 weeks at a stretch and then for shorter periods of time over 2 weeks. And I know that he is over 2 years, sorry. And I know that he's a good doctor who cares for his patients and does the best he can within a very under-resourced system. And then he said this, that he repaired a patient one day, surgically repaired her. Everything was open. It was a very bad tear. And he classified episiotomies as planned incision. Such extreme examples serve as cautionary tales for risk mitigation. While feminists, including I, have argued that routine episiotomies are example of obstetric violence, which they undoubtedly are, nearly 8 years later, I'm not entirely convinced that such actions should be read only through the lens of violence. It may be more productive to understand the ways in which a risk society operates, which compels health providers to act in ways that they do. Giddens argues, this is Anthony Giddens, the English sociologist, in risk society, there is a new moral climate of push on the one hand and pull between accusations and scaremongering on the other. Precisely because a multiplicity of futures is possible. If there are third degree tears, fistulas are possible, and in the worst possible case, a young woman or even a girl may have to spend the rest of her life with a stoma pouch stuck to her like a Siamese twin. This implies not only will she lose her marriage, but she will be carrying the stigma for the remaining days of her life. Her social life will have ended, even if she continues to be physiologically alive. So, this kind of scaremongering, which the doctor was doing here regarding episiotomies, that they are necessary because the risks of not doing them are so serious, particularly amplified in a constrained health system, is a better option than to surrender to that risk. So, in the Origins of Risk Society, which Ulrich Beck talks about, he says that there are two reasons why this entire concept of risk society originates. One is regarding the end of nature, where almost all aspects of natural life are affected by human intervention. And secondly, because of the end of tradition, where life is no longer lived as fate. A society that lives after the end of nature and after the tradition is very different from earlier forms of both peasant and industrial society. It is necessary to separate risks from hazards or dangers. While life in pre industrial contexts may have been dangerous, these were seen as fated. It's just luck. A fisherman goes out to stormy sea and never returns. Fate, God's will. Today's ideas of risks are bound up with this aspiration to control, particularly controlling our future outcomes. Society is increasingly preoccupied with future and safety, which contributes to how we see risks to ourselves and for our loved ones. Risk, of course, does not have only negative connotations. Taking a good risk in business is often rewarded. Capitalism rewards risk takers who are bold. Beck and Giddens view risks of two kinds: external risks that strike from outside regularly enough to be mostly predictable and therefore insurable, and manufactured risks which occur due to progression of science and technologies and new risk environments for which we do not have a historical blueprint. However, for countries like India with a history of uneven modernization, which Giddens sometimes calls reflexive modernization, where traditions and nature coexist, we are feudal but also democratic, secular but also deeply religious, egalitarian in some ways but also extremely hierarchical in others. A neat urban rural divide is also impossible. So, this idea that of risk society that both Giddens and Beck have do not necessarily neatly encapsulate everything that we are about to discuss or that I've already spoken about. The country has tried to manage what would be classified as quote unquote external risks for pregnant women through large public health interventions like NHM, which is supposed to tackle anemia, hypertension, gestational diabetes, and similar predictable risks at the population level. However, these interventions assume that people at risk of these conditions take the necessary precautions to mitigate such risks. For anemia, we know that iron folic acid supplementation has largely been a failure because not only do women not take these supplements, but also that iron deficiency anemia is only one kind of anemia. Even our Food Security Act only provides carbohydrate security, while anemia is the result of the loss of protein and micronutrients in our diet. Lowering of diversity of diet, hemoglobinopathies, reproductive health issues like loss of menstrual blood among young women, air pollution, gender bias that leads to nutritional neglect of women and extreme poverty, and a host of other complex pathways which science is yet to understand comprehensively. Trying to mitigate anemia through the NHM or even the Poshan mission alone is like taking a sword to kill mosquitoes. They move quickly, adapt easily, and they evolve constantly. Manufactured risks don't imply that risks are not real or that no one should be held responsible. But Giddens and others argued that they have emerged as a side effect of science and technology, which early theorists did not envisage. Science and technology create as many uncertainties as they dispel. These uncertainties cannot be resolved in any simple way by yet further scientific advance alone. Giddens argues that manufactured uncertainty infuses into our personal and social lives. One cannot rely on tradition alone to determine what to do in a variety of contexts. This leads to a more active, risk infused orientation to the relationship. So, a good example of this I find is related to doctor patient relationship. There is a bounty of scholarship on how doctor patient relationships have changed over time. And Datta et al. 2025 recently argues that trust is now at an all time low on both sides. Due to their embeddedness in both colonial and pre colonial hierarchies, healers have enjoyed prestige and authority in India. In post colonial context, especially with the huge privatization of medicine and commodification of health, things have changed dramatically. Patients endure disrespectful and abusive treatment or are exploited for profit. They were expected to be passive and listen to the doctor without questioning. That was the tradition. But this is no longer the case. In a well functioning healthcare system, there would be effective ways of mitigating these issues. But in a health system characterized by the chaos of huge patient footfalls, graft, where blood needs to be arranged using every last drop of one's social capital, doctors on continuous shifts and with no rest, the dehumanization of the providers and patients are complete. Naturally, there are moments of rupture. Violence against doctors and the vandalization of healthcare facilities, even if statistically are low probability events across India, especially compared to the poor treatment of patients or their financial exploitation, the possibility of this is a haunting presence in the lives of medical professionals. But it is much more than a presence. It has become one of the defining ways in which now doctors handle patients, always erring on the side of over caution, which translates to over biomedicalization during childbirth. Routine augmentation with pitocin, sometimes the application of fundal pressure to ease labor, episiotomy, C-sections at the slightest sign of fetal distress, repeated pelvic exams, and other interventions have become the ways in which health providers try to mitigate this manufactured risk. Note the following conversation with an OBGYN in a tertiary facility in North Karnataka. Again, this is work that was conducted when I was a part of this center. So in here, what this doctor is telling me is that there was a recent C-section that her friend had to do. And this was because the patient was brought in a state of emergency, obstructed labor from a CHC. That's a community health center, which was far away from there. The community health center had tried to induce her, but had also discovered during that time that the baby had presented in breech. So they transferred her to this tertiary facility. So she says that the husband did not come. It was midnight at 3 a.m. and only her father and brother were present with her. So I asked her, is it common for the husbands to not come? She says, yes, it is common. And maybe this is understandable because the first births often happen in the mother's home where the husband may or may not be accompanying the pregnant woman. Even male attenders will not come with the woman. In that condition, patients will be referred. At that time, we will be informing our higher authorities and they will say, take consent of whoever is available and proceed. We have to do like this because patients will deteriorate.
Sreeparna,
So,
quick
yes.
question. Is there a slide that you want to move to?
No. The next slide is about deviation from
Okay. All right. Sorry. Thank you.
No, so she has taken their consent and done the section. We have to do like this because patients will deteriorate. And baby extraction was very difficult. And this is her a friend who did the C-section at 3 a.m. On the 7th post-operative day, the patient had wound infection. So my friend called the attender. So her friend is a doctor. At that time, the husband was there. She told husband that there is a wound infection. The husband tells her, I was not there for section. I did not give consent for section. I would have taken her somewhere else. Who asked you to do the section? Why was it done? Whose consent have you taken? So then I asked her, wasn't the infection manageable at that stage? She said, yeah, nothing terrible happened at all. So I asked, did they take the patient away? So she said, yeah, they, took them, what they call discharge against medical advice. So they took them away. So the normal birth of patient X, what happens in this particular situation is that the doctors are now scared that anything might happen, right? So even this, I said what was scary about this interaction. She said that they spoke in loud voice and they behaved in such a way that it was really not not forget about comfortable. It was a little worrying. And also, as a young female doctor, she felt this kind of threat was something that she had to be alarmed about. At the same time, as you can hear from what I have described, the fact that women are still considered part of, as if they are the property of their husband. So they said, whose permission was taken when you did the C-section on her. So, Amma, how much time do I have left? Because I don't want to miss out on the conclusion.
Sure. No, you still have another 5-10 minutes to go. So,
Okay.
yeah.
So there's another vignette that I want to talk about. So here is about deviation from protocol, which was at a tertiary facility in North Karnataka. So here, as you can see, that they are aware that they are deviating from protocol because there is protocol. For example, C-section after that it's possible to do a VBAC, which is a vaginal birth after C-section. But because there are no monitoring facilities, we cannot wait for the evidence-based care and we have to deviate. So then I asked, are there situations, for example, practices like fundal pressure may be regarded as ineffective, but you think they're effective in these situations? So then again, this doctor says, yeah, fundal pressure, sometimes it will help, especially because when C-section is risky for the patient, it is helpful and a little pressure is helpful. And then I said, what about episiotomies? And the same thing she repeats. With regard to C-section, I want to highlight one thing. Recently, I was part of a conference where an ex-colleague from my graduate school was also doing her project in Nepal. And some of the findings that we had were uncannily similar. So for instance, this rise in C-sections that we see, which is happening in private hospitals, is very easy to explain because that is happening for profiteering. But what about public hospitals? Why is it happening in public hospitals? And this is happening in Nepal as well, especially in urban areas like Kathmandu, as well as from anecdotal evidence. I know it's happening in rural Maharashtra, and from the NFHS data, C-sections in public hospitals have also gone up. So C-sections, in fact, are emerging as a way to manage health system constraints because you can free up the bed more easily if you have a 48 hours planned C-section versus a woman who might have a labor which is not really definable. And unless or bounded, and unlike countries abroad, for instance, I know within the NHS, National Health Services of the UK, unless you are 8 centimeters dilated, they will not even allow you to give you a bed or allow you to come into the hospital. They'll send you back home. But in our system, that is not possible because sometimes there are women who come very far away from the peripheries. They would have had to use maybe multiple modes of transportation, gather up quite a bit of money in order to even make that journey. So the doctors cannot tell them that, you return. So again, this becomes another way of managing risk both for the participants, for the patients as well as for the doctors. So I want to conclude by, just a few thoughts. The concept of risk is directly bound to the concept of reflexive modernization. Risk may be defined as a systematic way of dealing with hazards and insecurities induced and introduced by modernization itself. Risks, as opposed to older dangers, are consequences which relate to the threatening force of modernization and to its globalization of doubt. They are politically reflexive. This is again a quote from Beck's book, which was written in 1992. So, in risk Society, Beck argues that while in the pre industrial world, problems were due to scarcity of resources, for instance, scarcity of food leading to famine, although we also have evidence that famine can be created by human beings. In the post industrial risk society, many problems were due to excess, for example, air pollution due to excessive industrialization. While the health providers here are reflexive, I am unsure whether, as per Beck, they are systematically dealing with hazards. In Beck's conceptualization, these hazards are both moral and material, which are the results of the very technologies that professes to minimize those risks. For example, for every case, depending on the patient profile, the current constraints within the facility, the risks of poor outcomes, etc., are assessed, not always through a deliberate and systematic process, but amid chaos and urgency. The patient may be given a referral or not. While health facilities at every rung are aware that their risk mitigation strategies are leading to patient overload, in the next rung, the risk or threat of punitive action or adverse outcome encourages them to pass the responsibility to the others. Thus, health system constraints, the political economy, and not just technology alone, create risky environments within which health providers must operate in ways to mitigate those risks as far as possible for themselves and their patients. These ironically lead to the opposite effect. For instance, through unnecessary C-sections or use of bundle pressures or universal episiotomies, you end up increasing patient risk. In Giddens' reframing of Beck's risk society, it is a preoccupation with the future and safety, both of which seem uncertain that may drive such actions. The question of safety, in particular doctor safety, is foregrounded by many of our respondents because of the increasing attacks on health personnel in India. So the last thing that I also want to say with regards to this is that, see, there are many entry points to understanding issues. And as you can see from this picture of this banyan tree with roots and shoots and branches going off in every direction, feminist epistemology, which regards disrespectful care, a result of the devaluation of women and gender inequities, is an equally valid way of looking at the problem. But after about 10, 11 years of engaging with the subject, I have found that to not be adequate for really understanding what is going on. Because in my conceptualization as well as analysis of the data and my ethnographic insights, what comes across very clearly is that it's not as if health providers are motivated by malevolence. Some of them might be, some of them, could be genuinely evil. I am not discounting that possibility, but the vast majority are not. And yet we see such negative outcomes. And I'm talking mostly about the public sector because my research from the private sector shows that profiteering, but also risk mitigation through minimizing instances of litigation is one of the reasons why there are so many instances of C-section. But at least in the public sector, I have seen that the health providers do try their level best. But given these risks that they have to encounter in modernity, some of them, facilitated by the technology themselves, compels them to act in ways to minimize risk. So with that, I will end today's talk. I had a lot more in the paper, but I skipped through some of the parts because I do want to leave enough time for question and answer. Thank you for your attention, and I'll be happy to take questions now.
Thank you, Sreeparna. That was a very thought-provoking and the kind of talk I think that raises perhaps more questions than it answers. And I suppose that was your goal as well here. This was And there's a couple of questions. I encourage people to please put questions in the chat box. But I'm going to, I want you to unpack that term that you use from Beck, globalization of doubt.
Yeah,
I think that phrase really struck me. And
right.
how would you, and where does doubt function with respect to risk, because sometimes they
Yeah.
overlap, but they're also very distinct. And I was wondering if you could talk about that a little bit more.
Okay, so what I want to say is that so when he says globalization of doubt, what he means is that the role of the expert now has become secondary. Right. So in say 50 years ago, we used to listen whether they were doctors or engineers. There was a role for education and highly educated people, and their expertise meant something. But everything that we see today is cast in a layer of doubt. I'm talking about things which are empirically involved or informed, not ideologically informed. Beck was writing his book in the 1990s, and if he had, and I don't think he lived long enough to see the misinformation and disinformation wars that are happening. But what he's trying to say here is that everything now is taken with a grain of doubt, with a grain of skepticism, and this globalization of doubt is something where it's also kind of overlaps with the end of tradition, where everybody knew their place in society. So if you were the son of say a businessman, you were expected to continue the family business, or if you were born into a family which had lots of priests, you were expected to continue doing that. With greater individualization, which has happened with the end of tradition, you see a lot more doubt and skepticism that has also entered the way in which we interact with people. So when he's talking about the globalization of doubt, he's talking about it both with regards to different aspects of our lives, but also across countries around the world.
Thank you. That was really some food for thought there. A couple of questions that have started to come in. Dr. Anthony Colonur, actually, first he starts with a compliment. He says he loves your beautiful language while presenting, critical questions and facts, and I will agree with that. But he also asked, the perception of risk differs with the level of scientific knowledge between the doctor and the patient. Is it ethically correct to expect the illiterate patient to give an informed decision, on a medical intervention to save his or her life? Or is it a patriarchal sort of interaction which disrespects individual freedom?
Thank you for the question. I think this is a question I'm also struggling with. The problem is that, like I said in the beginning, one of the first propositions of science is that science is built on uncertainty, and every knowledge, sort of everything that we know is provisional. But how do you explain this, what seems like a very simple sentence, but encompasses such profundity to someone who has never been to school, where they are looking to the doctor, maybe, to give them advice on certain things? I am not really sure that it's fair that that we kind of hold both of these at par. But more than the question of fairness, what struck me when I was, and I think the example that I gave of the intern was talking about how, they think that C-section is very routine, very normal, but the patient thinks it's a big deal because it is an operation. But it is an operation. So what I'm trying to say that even for physicians, I don't think it's always clear what the right path to take is. Every decision is cast in certain amount of risk. Whether or not they admit to it is a different thing. But I think everyone who enters surgery or the OT, things can go wrong. I think the fact that things can go wrong is something which we were a lot more comfortable with before the advent of technology, which itself was to minimize these risks. Now that we have more technology and we have, a lot of our, I suppose, time and energy is spent towards controlling the future or somehow predicting the future. right? That's why you have the futures market. You have all these models of how things work. Earlier, there was a lot more, I suppose, for instance, if you look at end of nature again, there was a lot more surrender to the fact that bad things happen. People did not grieve miscarriage, stillbirths, infant mortality the same way that people grieve it now, because it has become a very rare event thanks to technology, especially in upper middle class homes, especially in highly resourced settings. But even today, I don't think that, especially in the context of childbirth, that it's a completely risk-free event. I think, and here I'm drawing from some of the work that I've been doing with people who have chosen not to have children, which is my more recent work. I think many of them who are extremely well read and well read to the point, and women that they know everything that happens to the body when a woman goes through pregnancy, they have decided that is not a risk they want to take. That is one of the reasons why many do not want to have children. So, no, it's not, I don't know if I've answered the question. It may not be fair, but I think that understanding that both are operating with a certain degree of blindness, although the degree is vastly different, I think is a good starting point.
Thank you.
In terms of reparation of relationships, because I'm really thinking about, the doctor-patient relationship, and we have become so accustomed to doctors being so confident about what they do. Most people don't like it if a doctor says, I'm not sure. But I think that somewhere we have to accept the fact that we don't have that certainty, how much, we may desire it very much, but we really don't have it.
Thank you. Revati asks, first, once again, she compliments you for bringing this sort of discussion into the mainstream. But she asks, are there initiatives to make this epidemiological terminology more accessible to patients and their families? And perhaps she asks whether ASHA workers could have a role in bridging this gap.
I think that I don't know whether there are attempts to make it more translatable, but I think what epidemiology has done has erred on the side of scaremongering, not wrongly so for some things. So, taking tobacco is one of them. Tobacco causes cancer. We have that every day. We have enough evidence to show that is the case. Does it mean that for every single individual who consumes tobacco, it will cause cancer? Maybe not. So I think that I don't know whether ASHA workers, they themselves are from the community. They don't always possess a very high degree of education, and more than education, I think they don't always have the time or the mental space to understand all of these things, right? But to a large degree, people have a good amount of epidemiological knowledge where vaccinations are concerned, because we have a very good record with immunization and with polio or measles. There are many illnesses which have been tackled through immunizations. So I think that also with COVID, people have become more familiar with medical language. So there's a lot of medical speak these days, and private sector doctors are very frustrated with people who Google their conditions and come and talk to them about it. But at the same time, at the cellular level, at the molecular level, do we really understand what's going on? But for that matter, unless the doctor is also a scientist, do they also understand what's going on? So I think that there needs to be a lot more efforts towards evidence-based learning, not just epidemiological learning. And that needs to start from school. And I don't think that that's really happening. As a college teacher, I see students coming with large gaps in their critical thinking. Their ability to question, to think critically, is the foundation of later medical literacy or epidemiological knowledge. If that is not happening, then how do we do this as adults? right? So the example that I gave of how the knowledge, attitudes, behavior, practices model can help was in the context of a study which showed that when children are exposed to the material on environmental change and human, man-made climate change issues, when they are young, they are less susceptible to misinformation and disinformation. So really inoculating them and treating this as a virus. So if we want more people to become a lot more, certain about evidence and using that evidence for their own well-being, we also need a population that thinks critically. And I don't think we are there.
I think this actually links to a point made by Dr. Ravikant in the Q&A, which is he says that women actually don't often have a lot of autonomy in their hands in these settings. So so he poses it as a statement really. So education opportunity should be strengthened, but I think the point you're making is that it's not just about education, but it's about being able to think critically about what risks mean in this context and how on what basis one makes decisions in these contexts.
Yeah. I think a certain kind of education is important, and even among highly educated women, think the family plays a big role in deciding for themselves. So you can give consent, but often the next of kin, who is typically the husband in cases of married women, also have to give consent, right? So there may be situations when it is a precious baby, when people are forced to do this. So I want to share another anecdote about C-section, and that has to do with how doctors approach it. So medically trained doctors, I've spoken to quite a few of them. Some of them have a very child-centric view of labor, where they say that C-sections are the least risk-free option when it comes to children, because you are less likely to have a child born with, far less likely to have a child born with some kind of disability like cerebral palsy or anything, because protracted labor is not going to occur. So I think that whether we are going back to the question about critical thinking, women's autonomy, in one particular case, what I the wife was also a doctor, and the doctor was saying, yeah, my wife agreed, we both had our children through C-section. So of course I didn't have the opportunity to interview the wife, but there is, it's not as if there is no resistance. There's also resistance where you have women who are going to these posh birthing facilities which provide a natural birthing environment, home births, midwife-led births, and so on. But those are beyond the reach of a vast majority of our population, right? And even those are where they try to mitigate those risks by having these birthing centers connect to hospitals. Because should anything go wrong, then access to a hospital is immediately possible. So women, I think, overall, if they are disempowered in most aspects of their lives, we cannot expect them to suddenly become empowered when they are in a situation, in this kind of a situation of medical decision making.
I think Sanjana has an excellent question, and I was thinking about this too while you were speaking, which is that the discussion when we talk about risk, we talk about epidemiological risk, or at least that's the understanding. But I think as she points out, there's a different kind of risk that doctors perceive, and she's been working on violence against doctors, and she says that sometimes doctors get the risk that's perceived by patients and attenders, and sometimes they do more than they're supposed to because they think that the risk of poor outcomes means there's consequences for them and they have to be more defensive.
Yeah.
So she asks, what is the solution? I mean, is it better PHCs and with facilities, or is there any sort of programmatic or policy response to the problem that you're raising? How does one address, I think these different the epidemiological risks, I think, are sort of how to address them are, I think, better understood, perhaps. I mean, it's still an imperfect science, as you pointed out. But what about this kind of risk?
Yeah, so this kind of risk was, what I was talking about when I was saying that our interactions and orientations have become infused with risk because we live in a risk society, and particularly in countries like India, where ways of securing accountability has become through either actual violence or the threat of violence. So it is a symptom of a very poorly functioning health system. So from a programmatic perspective, if we do want to, change that, we have to begin with at least trying to repair this relationship. And with the extent of privatization and commodification of, medicine that we've had and health, I don't know that we can turn back from there. I mean, take the example of, a lot of us have parents who are senior citizens. There are instances where people, for no good reason, are put in the ICU. A battery of tests are asked that, you go do these tests. How can we expect patients to have trust in doctors when the trust has been violated at the altar of profiteering? So, if we want things to change from a programmatic perspective, I think the first thing we need to do is bring about some very serious regulation of the private sector. For the public sector, I feel that it needs to be far better resourced than it is. The public sector resourcing has just reduced. And, I've not just in Karnataka or Assam, I've also seen examples of public sectors in Maharashtra, I've seen it in West Bengal. And sometimes, I mean, a lot of the times you are just sort of in awe of the doctors who are operating under some really inhumane conditions. There is no better way to put it. And that's not just in the hospital, that's also the interns who live, the students who live in the hostels. There were all these instances when there was an outbreak of multi-drug resistant tuberculosis in Mumbai, when quite a few of them died from catching it because they were malnourished. The food was so bad in the government, mess. And they were dealing with patients who had ex MDR TB. So I think that we need things to happen on both sides. We need a lot more regulation and monitoring of private sector hospitals, and on the public sector side, we need a lot more resourcing and a lot more, less informalization and contractualization of work. And the state really needs to step up and look at the conditions of work. It's not enough to have say that 1 year compulsory you will be in the rural areas. Why should it be a punishment posting? Why shouldn't it be an opportunity for doctors to learn? If the conditions were good, then I think many doctors might take this up as an opportunity rather than consider it a punishment.
I think this also gets to Madhumita's question about how do you deliver respectful maternity care in the context of these under-resourced settings, but I think you sort of addressed that. And Dr. Collinor, Dr. Anthony again brings up a point, which is that when we talk about risk, that currently doctors have become more aware of the risk to their security and reputation rather than the risk of collateral damage to systems or side effects upon the patient, when they over-investigate or embark upon radical treatment. So, so thank you for that addition as well. Saurav actually brings back Beck's ideas of irrationality and hostility in the Indian context. And he says that the deviation is often systemic rather than psychological. He actually makes a couple of points here. One is that, not all irrationality is due to hostility. It's often due to inadequate communication, socioeconomic barriers, and lack of trust, which I think you've spoken about a bit here. But he also speaks about the risk invisibility in poorer communities where high infant or maternal death is normalized, and the converse in urban areas where there's an over-medicalization and fear of natural birth, showing a flip side of perceived risk.
I think so. If anything at all, for instance, this last point C, conversely, in urban areas, there's often over medicalization and fear of natural birth, showing a flip side of perceived risk, is deviation which is psychological rather than systematic, right? So, systemic deviations with protocols do happen. For reasons that I have already underlined, because I certainly feel that this is a risk management strategy, especially in public sector hospitals, where private sector hospitals are concerned. Risk invisibility in over medicalization also happens because of things like litigation. And the irrationality that Beck talks about, he says that it is the perception of the experts and when he says experts, I think he's mostly talking about engineers and scientists, that the irrationality is because of inadequate understanding. And that, so I had put all of those in quotes because it is the expectation that they are irrational, that they don't have a good understanding, that because they are saying no to technology, naturally they must be hostile to technology. So this is what Beck is saying about people who are not buying into all the latest technological, interventions. So I think that uh, I don't see this distinct from a psychological or a social process which is different from a cognitive process. For me, all of this, and I think not just for me, but for social scientists and mostly anthropologists at large, see all of these quite entangled with each other. We don't really compartmentalize saying, oh, this is cognitive, this is emotional. They kind of come together to produce a certain understanding of risk.
I think, I mean, the flip side of risk, I think that you've been speaking all along about is trust. And um, I think it speaks to the anecdote that you opened with as well, which is right. There was, I mean, it was miscommunication at some level, a lack of understanding at some level, but there was fundamentally like an issue of trust there. And I think Asha brings this up in her question where she says, you mentioned that a doctor admitting to uncertainty would undermine patient confidence, but acknowledging uncertainty along with the actions to manage it can actually be helpful. Perhaps something like that can build trust, can be perceived as empathetic. Do you think? Can you speak on?
I totally agree with that. In fact, that is the thing that I was suggesting. But I suppose that we have become so used to the doctors telling us what to do, right? That I don't think as a population we are really prepared for that kind of uncertainty. We take that as a lack of expertise or a lack of knowledge when you say, this is what we think might happen. But the might here or will is different from will happen, right? So we don't I think what I'm saying is that we don't necessarily want a doctor or any kind of health provider or team based practice. I mean, team based practice is something I was not able to bring in, but that is another reason why in the private sector you see such a high rate of C-section. Because there was a study in Delhi which showed that, and the NCR region, that the lack of team based practice means that if there is a normal birth, the doctor will never be able to sleep because they have to monitor the patients throughout, right? So when you have a team, but a team based practice also means that you have to have trust. But in a risk society where you feel that everyone has to guard against a personal risk to their reputation or other kinds of risks, then it's very hard to also build that trust, right? So yeah, I think that trust is obviously the flip side, but trust also comes with knowing that there will be uncertainties, there will be some unknowns, that we won't have complete knowledge about the future.
I think that seems like a good sort of point to end this conversation on, because I think we've come full circle here with the point that you're making or that you made during the talk about how we sort of want to control the future. And these are all actions that we take to grasp what is ungraspable. Thank you, Sreeparna, for this really sort of very clever talk, actually, I think, to make us think deeper about the terms that we use. I think we use the terms in public health like risk very in a very singular sense. And I think unpacking what that term means, not just in the context of obstetric care, as you largely spoke about today, but other forms of public health interventions and so on as well, this was very helpful to think about. Thank you for your time today and for generously participating in this discussion as well. And thank you to all the attendees who come today.
Thank you for inviting me. It was really good to have the opportunity to engage. And I'll keep thinking about this. So if any of you have other points that you want to share or that come up, so feel free to contact me and let me know as I think through more of these.
Lovely. Goodbye, everybody. Thank you.
Goodbye.